Good afternoon, everyone, and welcome to the Support Hospital Opioid Use Disorder Treatment Shout, Texas. Echo, please know that we are recording this session for later distribution. Know that your names do not appear on the recording of the session, nor does anything listed in the chat. Thank you all for joining us today. My name is Shreya Prasanna, and I'll be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat feature to help us with our record keeping. We appreciate your support in helping us fully capture this. We love to see everyone's smiling faces, so if you're comfortable and able, please join us by video, especially for the discussion portion of this session. We invite everyone to speak, but we ask you to stay muted unless you are speaking. To mute and unmute, select the microphone icon on the bottom left of your screen if you join on a computer, or if you've joined by phone, use *6. You can also communicate with the chat feature to raise questions and ask comments. Please know that no protected personal health information is allowed in either the chat or our discussion. During and after the session, the Shout Echo Texas Echo team will send out a link to an evaluation of the session. We appreciate you filling it out to provide us with feedback. Our didactic today is on health equity primer around substance use disorder in the hospital setting. Following that, we will discuss a case presented by Dr. Lindsay Mainberg from Ascension, Texas. So we will start with introductions, followed by didactics, announcements, case presentation, and open discussion. Thank you again for joining our Echo today. In the spirit of all teach and all learn, we encourage you all to share your experiences, questions, and insight in today's conversation. We'll get some introductions started. So we'll start with our hub team, Dr. Ramesh. If you could please introduce yourself.
Hi, everyone. I'm Dr. Ramesh. I'm a hospitalist over at Dell Medical Center.
Thank you for joining us. Dr. Walker.
Hi, I'm Blair Walker. I am a psychiatrist, chief of psychiatry at Dell Seton Medical Center, and I help co-found our B team or buprenorphine team. I'm the clinical lead for that here.
Thank you. Dr. Botner.
Hi, this is Rich Botner. I'm a physician assistant at Dell Medical School, and I, along with Blair and others, participate in the B team and help co-lead that effort, and I'm excited to be here.
Thank you for joining us. Dr. Patel.
Hi, everyone. Snehal Patel, one of the hospitalists for Dell Med as well, also part of the B team. Very happy to be here.
Thank you. Dr. Mainberg.
Hi there, I'm Lindsay Mainberg, and I am from Ascension Seton. I'm a clinical pharmacist and the pharmacy champion for our B team.
Thank you. Alana.
Hi, everyone. Good afternoon. I'm Alana Bolton. I am a program manager at Dell Medical School over our Shout Texas program.
Thank you so much. And Andrea Handler.
My name is Andrea Handler, and I'm one of the project coordinators for the Echo sessions. Happy to be here.
Thank you so much. And since it's a small group, I'll just open up everybody to kind of quickly introduce themselves. So Ada.
Good afternoon. I'm Ada Sapp, the psychiatric mental health nurse practitioner here at Baylor Scott and White Health Memorial and Temple.
Thank you so much for joining, Ada. Lauren.
Hi, good afternoon. My name is Lauren Hicks. I'm the Texas account manager for Alchemies.
Thank you so much. Andrea Rocha.
Hi, Andrea Roche, program manager for UT Health San Antonio Echo. Glad to be here.
Thank you. Sue.
Hi, my name is Sue Balazantis. I'm one of the medical directors for Scott and White Health Plan.
Thank you for joining us. Megan.
Hi, I'm Megan Clark. I'm a PA. I just joined the HEROES program in Houston.
Thank you. Emily?
Hi guys, my name is Emily Ibarra. I work at Harris Health System at Bentop Hospital with our substance use program for pregnancy, maternal perinatal.
Thank you for joining us. Grace Diaz. Grace, are you able to unmute and introduce yourself? Okay, we'll move on. Please chat us your affiliation, Grace and William.
Yes, hello. Hi, good to be here. My name is William Thomas. I'm the supervisor for the office-based opiate treatment program at Emergence Health Network in El Paso, Texas. Unfortunately, I'll have my camera off because it cuts on my internet and it makes you guys kind of skip around, but I am here and it's a pleasure to be here. Thank you.
Thank you for joining us.
No, thank you for the invitation.
Dustin Dumas.
Hi, I'm Dustin DeMoss. I'm the medical director for Psychiatric Hospital in Fort Worth, Texas, and I'm helping launch our addiction service here at John Peter Smith Hospital Network. And I've been working with Rich and Alana and team with the Shouts to help further that effort. So I'm glad to be here.
Thank you. Rhoda Hall.
Hi guys, my name is Rhoda Hall. I'm with Premier Care with Midland and Odessa. I'm the PAC counselor.
Thank you. Maddie Escamilla. Sorry, I didn't get your last name right.
It's okay. Hi, I'm Maddie. I'm a physician assistant with behavioral health at JPS Hospital, also working with Dr. DeMoss with the SHOUT program here at our hospital.
Okay, thank you so much for joining. And Mary Healy. Mary, are you able to? Okay, sure.
Yeah, I'm Mary Healy, and I'm a quality improvement specialist from TMF Health Quality in Austin, Texas.
Thank you. And Veronica.
Oh, hello, everybody. I'm Veronica. I'm an addiction psychiatrist at Baylor Scott & White and Temple.
Thank you for joining us. Thank you so much. This is an awesome group. I'm so excited to hear our conversations today. Let's move on to our didactics. Dr. Patel, I believe you would be sharing your the slides yourself, so you can get started. Thank you so much.
Wonderful. Okay, can you all see the slides or the first slide? Yes, okay, great. So I'm really honored to be here. Great, I'll start by letting y'all know that you know, I'm a hospitalist. I've been working nights this week, and so I apologize if I am a little bit foggy over the course of the next few minutes, but my name is Snehal Patel. I'm an internal medicine hospitalist at Del Seton Medical Center and assistant professor of medicine at Del Med. I'm also a community organizer and labor organizer in Austin, Texas. So we're going to talk a little bit about health equity as it pertains to substance use disorders with a focus on the inpatient side, but really relevant to larger discussions around the intersection of equity and treatment. I have no relevant disclosures to report besides, as I think I probably share with everyone on the call, being really invested in improving community health and the care of our patients. Some of the learning objectives. So here's the learning objectives that we set out: to describe principles of health equity and intersectionality with substance use disorders, to summarize the importance of health equity and substance use disorder care, and to provide examples of improving health equity for people with substance use disorders during hospitalization. So as with any conversation around equity and justice, I want to start with the recognition that our current state of health systems are really built on the land and labor of others in ways that have, frankly, fundamentally violated principles of equity, right? Our country has been built on violence and erasure through enslavement, forced labor, settler colonialism, imperialism, ongoing wars today. And in Austin, as with much of present-day Texas, the displacement of indigenous peoples, the forced unpaid labor of African descendants, the unpaid and underpaid labor of immigrants, both historically and currently, is part of the backdrop of our current systems, including our healthcare system. So I want to start by acknowledging this. And all of our education, all of our work happens on indigenous lands. in many ways, the colonial process is not just a historic context, right? The logic and policies of racial colonial capitalism drive most of our current care systems, including our hospital care systems. And I start with this because any conversation around equity in substance use disorder care and treatment in or out of the hospital has to reckon with these forces of racial colonial capitalism and the ways that it manifests in our healthcare system. So if we're really interested in actually building toward equity, we have to reckon with this as providers within hospital systems. And while the goal of health equity is inclusive of all communities, I'm going to argue that it really can't be achieved without an explicit recognition and reconciliation of our country's twin fundamental injustices of genocide and forced labor. The particularly devastating toll of COVID on communities who have been minoritized and or historically marginalized, coupled with worldwide protests against racism and police violence, has brought a lot of people, including clinicians and health systems, into conversation around racial justice and health equity in a way that we've seen a resurgence really over the last year and a half. In recent years, we've literally seen through phone video footage the ways in which the state, through aggressive policing, literally kills hundreds of Black and brown individuals around the country, right? A practice that's not new and goes back for generations, really goes back centuries. Tying this to substance use disorder, right? Breonna Taylor died as a result of the racist war on drugs, which created a pathway for no-knock warrants, a policing tactic that ultimately led to her death. The legal defense for the police who killed George Floyd rested in the derogation and denigration of a Black man with a substance use disorder, right? We're not gonna, I don't want to, we don't have time to really go through the full history of the war on drugs in detail, but really this didn't start with Nixon's campaign in the 70s and sort of the doubling down on racist policies in the 80s with the Anti-Drug Abuse Act, but goes back more than a century. Looking back at the Harrison Narcotics Act of the early 1900s, which was pushed forward by white politicians across the country as a way of denigrating Black Americans, Mexicans, Chinese laborers by using drug enforcement as a method of criminalization and subjugation of non-whites, right? So why do I bring up this history? Because what I would argue we're seeing now is a continuum of the same historical processes, arguably at more rampant levels in some ways when it comes to disproportionate criminalization and imprisonment due to drug-related charges. And I would also argue that this has everything to do with how we think about improving equity and care around substance use disorders. So I'm not going to go into the details of a lot of this research. There's a lot of data that's out there, especially over the last couple of years, looking at health inequities in substance use disorders, disorder treatment by race and ethnicity. I'll go through a few specific statements here. So, according to a recent SAMHSA report, Black and Latinx individuals have a disproportionate burden of health and social consequences from substance use, despite having a lower or equivalent prevalence of substance use and substance use disorders. For example, marijuana use is roughly equivalent among Black and white people, yet Black people are almost 4 times as likely to be arrested for marijuana possession. We know that medications for substance use disorders, opioids in particular, as well as alcohol, decrease all-cause and overdose mortality. And despite a faster rise in opioid use disorder overdose deaths among Black Americans, the opioid crisis in many ways is still conceptualized currently in sort of the general public consciousness, as well as in clinicians' consciousness, as a white epidemic. For Black Americans, 89% of those diagnosed with a substance use disorder did not seek out or receive addiction treatment, and Black patients are significantly less likely than white patients to initiate medications for opioid use disorders. Black patients have half the odds compared to white patients of using buprenorphine or any medication for opioid use disorder, and are less likely to be prescribed medications for alcohol use disorders. And Black patients are half as likely to obtain treatment following an overdose compared with non-Hispanic white patients, even when privately insured. So that, there's been some increasing acknowledgement in the media around these topics over the past few years, as some reporting around this study from 2009 that showed that white Americans with opioid use disorders are about almost 35 times as likely to have a buprenorphine-related visit than Black Americans for treatment. Through the last 10 years, through the 2010s, there's been a lot of discussion about increased rates of drug overdose, in particular amongst white men. But other key demographics affected by this epidemic have, I would argue, been overlooked, right? So in the first 10 years of 2000, women experienced a 400% increase in rates of prescription opioid-related deaths, compared to about 200% increase among men. And rates of deaths from overdose are increasing more rapidly, as I mentioned before, among Black and Latinx individuals compared to whites. But there's still little attention and treatment directed towards these minoritized communities. So why do we have such significant treatment gaps? I'm going to argue that treatment gaps are due to multiple intersecting systems, including federal and state level policy, drug-related policy. We have inequities in addiction treatment models, and we have inequities in healthcare delivery systems. Underlying this, structural racism, discrimination, social injustices play a significant role in substance use in communities of color and play a role in racial disparities in substance use disorder treatment. Right? We see racial differences in criminal justice system involvement due to racism that exacerbate disparities in medication initiation and retention, as well as trust amongst individuals, in particular people of color. It's policies at the federal down to the organizational levels that foster and drive some of these inequities, and social determinants of health and health-related social needs, such as housing instability, food insecurity or security, exposure to violence and trauma, institutional racism, discrimination, poverty, can all drive the perpetuation of negative outcomes from substance use disorders, and also provide us an opportunity to improve our focus for treatment. And I know I'm going relatively quickly here. Anybody can feel free to jump in if you have thoughts along the way. So when we talk about health equity, what do we mean? At Delman, we've been wrestling with this quite a bit, and the consensus here is that to use the Robert Wood Johnson Foundation definition of health equity, and that is that health equity means that everyone has a fair and just opportunity to be as healthy as possible, and this requires removing obstacles to health such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. So this is a very broad-reaching definition, right? It makes us think about health equity as more than just equitable medication-based treatment, but really working to address obstacles to optimal overall health. Right? Health inequities arise when certain populations are made vulnerable to illness or disease, and often through the inequitable distribution of supports and protections. Health inequities are gaps that are unjust, avoidable, unnecessary, and unfair. They're not inevitable, right? They're produced and sustained by deeply entrenched social systems that intentionally and unintentionally prevent people from reaching their full potential. So I think many of us have probably seen these graphics comparing equality and equity. And I'm going to ask if anybody wants to unmute themselves and sort of briefly narrate these images. What do you notice in these images? If you could describe some of the differences that you're seeing between equality and equity.
The exact same box, but it doesn't accommodate people who need a taller box. So it basically sets up an inequity on the left, and then you show how you can accommodate and make it actually equitable for everybody on the right.
Yeah, I appreciate that, Dr. Walker. Right. So on the left you have three individuals of different heights, with one in a wheelchair. They all get the same box to try and look over the fence. The tallest person probably didn't need a box, and the person with the wheelchair, the box is really useless, but they got one anyways. and they're not able to watch the game. And on the right, the image basically shows that the three individuals are getting what they need, given what they need according to what they need, right? So 2 boxes for one and a ramp for another in order to be able to watch the game. So I think this is a really useful depiction in differentiating equality and equity. And I know that, again, I think probably many folks have seen this depiction before. And, one thing I want to argue is that in this framing, the individual's ability or inability to watch the game is because of their height to see over the fence, right? Sort of subtly suggesting that some individuals are innately or biologically determined to be less apt to succeed or less apt to be able to look over the fence, right? And are going to need more support to be able to look over the fence. And in the equity graphic here, they get the support that they need. I think the framing of what equity means is really important. It helps us define what we understand the problem to be, right? And from there, it helps us define the possibilities for intervention, right? So one of the challenges to this graphic around equity is that neither of these images really account for history. They don't account for the fact that inequality is not natural by its design. It's not natural, but it's really by design in many ways, right? The fence is created. That our systems function to produce inequality, not as a byproduct, but as a part of the routine functioning of our systems, right? So these images, in some ways, don't account for historical structures of oppression and privilege. So in this image, Marcelo and Shadowin depict 3 different individuals, right? They're all born and having grown to the same height. One is forced into a ditch, one is chained to the ground, and one is standing already on a block of privilege, maybe, perhaps. So sort of making clear the forces of oppression and privilege in our way of thinking about equity. So this reframing helps in some ways to redirect how we think about difference, and then can potentially inform the types and quality of our interventions, right? How do we make the root causes of health inequities more visible, right? How do we connect structural inequities, structural racism, social determinants of health in the discussion on substance use disorders and inequities in treatment, right? How do we turn things that have been made to be invisible? How do we make those visible in order to frame our conversation of what is it that we're actually trying to challenge? So I want to take just a minute here to define racism and structural racism in particular, and I'm gonna go by Dr. Kamara Jones's definition here. Dr. Jones is a visionary public health epidemiologist and physician. She used to be the head of the American Public Health Association, and she defines racism as a system, right? So a system that consists of structures and policies and practices and norms that structures opportunity and assigns value based on phenotype, or the way people look, and that's what we define in the U.S. as race. It unfairly disadvantages some individuals and communities. It unfairly advantages some individuals and communities, and the system as a whole saps the strength of the whole of society through the waste of human resources. And so it's a system, right? Sometimes a lot of times we get stuck in thinking, am I a racist, or is that person a racist, or is this a racist action? And though I think that's part of thinking about racism and different levels or layers of racism, what I'm referring to here is systemic and structural racism, right? What Professor Bonilla Silva calls racism without racists, right? This system that perpetuates racism without requiring individual level racist actors, right? So how, and sort of applying this to our hospital systems and health systems, how do our hospital systems, working within the larger environment of our cultures, how do they perpetuate structural racism in their sort of day-to-day action, day-to-day work, in our day-to-day work within these systems? So I want to turn to talking a bit more about some of the drivers that influence treatment initiation and access, and then and this kind of goes back to some of the social and structural determinants of health that determine treatment and outcomes. The war on drugs, as we briefly talked about, has created a disproportional criminalization and incarceration of minoritized individuals, but has not addressed the drivers of substance use, right, which are typically rooted in and perpetuated by trauma, historical and current trauma, collective and individual trauma, poverty, and other socioeconomic factors. And the result of the war on drugs has been mass incarceration of people of color in particular, and the fallout continues today. So looking at marijuana possession, and I know a lot of our discussion is around opioid use disorder, but I bring this up because I think a history of involvement with the criminal justice system is particularly relevant to how we think about substance use disorder and opioid use disorder treatment. So looking at marijuana possession with an increasing numbers of states legalizing or decriminalizing cannabis, we've seen over the last decade no reduction in national trends and racial inequities and rates of incarceration for Black folks compared to white folks, right? Today, in some states, Black folks are up to almost 10 times more likely to be arrested for marijuana possession than white folks. And incarceration for substance possession disproportionately impacts people of color, right? And this affects not only individuals who are incarcerated, but their families and their communities. According to this recent analysis in Texas, Black people were 2.6 times more likely than white people to be arrested for marijuana possession, with 44% of all drug arrests being made for marijuana possession. This makes up 18% of all state misdemeanor cases and 33% of a full third of all new felony cases. So in her book, The New Jim Crow, legal scholar Michelle Alexander analyzes the U.S. criminal justice system's use of the war on drugs as a primary tool for enforcing traditional as well as new modes of discrimination and oppression, right? She talks about how mass incarceration is a well-disguised system of racialized social control that functions in a manner very similar to Jim Crow, right? And this social control culminates in what she calls a racial caste system, a type of stratification where people of color are kept in an inferior position through criminalization, right? She makes analogies on how other systems, including health systems, reinforce the role of social control that the criminal justice system takes on. And this has significant repercussions in our ability to provide adequate and trusting treatment for people of color who use drugs. You can see in this graphic on the right, the discrepant lifetime likelihood of imprisonment for Black, white, and Latinx men and women. Black men have a 1 in 3 chance of being imprisoned, with an even higher proportion having any criminal justice involvement. But as in conversations around racial incidents and specific diseases, right? This is not due to some kind of genetic or innate issue of being Black, white, or Latinx, right? This is due to the effects of structural racism playing out in multiple systems. This schematic, and I'll go through it relatively quickly, but looks at how racism and/or the lack of economic opportunity can lead to prejudicial treatment in the justice system, which can trigger a vicious cycle that increases a person's risk of poor health in several ways, right? So discriminatory treatment by courts and police increases likelihood of incarceration leading to worse health through exposure to unhealthy conditions during incarceration. Thinking of overcrowding or COVID. Incarceration leads to worse health after release through social exclusion and marginalization, barriers to employment, decreased work earnings. Social exclusion leads to greater poverty, powerlessness, potentially homelessness, further exacerbating the risks of poor health. And this brings forward the theory of sort of syndemics theory, right? Suggesting that co-occurring adverse conditions in particular, interact synergistically to worsen the negative effects of each other, causing an increased burden than either condition alone, right? So it uses a socio-ecological model to take into account the structural, the interpersonal, the individual factors. So for example, structural factors increase substance misuse in response to, say, housing instability, displacement, homelessness, lack of employment, underemployment, racial and gender discrimination. So being involved in the carceral system can lead to exclusion from employment, housing opportunities, ability to get financial assistance, access to civic participation, voting rights, a number of lifelong harms and as well as greater instability for individuals, families, and whole communities. And when I refer to the social determinants of health here, I'm really talking about the underlying community-wide social, economic, and physical conditions in which people are born, grow, live, work. They affect a wide range of health and quality of life outcomes. We know that folks are dealing with addiction and going without treatment, and that inequities in treatment are high for racially minoritized persons, and that outcomes are worse for minoritized populations. And there's huge mistrust in healthcare systems, especially for folks who have had any kind of criminal justice involvement or negative police involvement, including ICE detention or similar situations. And so our healthcare systems, I would argue, aren't necessarily helping folks get into treatment, partly because we're not dealing with the criminalization of drug use for minoritized individuals, right? Whether that's, folks who are minoritized because of race, ethnicity, or gender, sexuality, or other reasons. And so until healthcare systems, hospitals, healthcare providers deal with some of the issues of inequitable criminalization, it's really hard for us to build lasting trust with folks who have been involved within the criminal justice system, which I think is a big part of conversations around substance use disorders. So, we talked a little bit about how racial and ethnic minoritized patients have worsening substance use outcomes, and this is we've seen this exacerbated by COVID. We've talked a little bit about legal policy and state policing creating a disproportionate criminalization and incarceration of minoritized individuals. And our health systems and health regulatory agencies, I would argue, continue to overlook these inequities and center, in many ways, whiteness in their treatment approaches. Right? So, unconscious messaging from regulatory agencies showing who's able to be involved in treatment, who's not, who's worthy of treatment and who's not, and even in some ways defining, who has an opioid disorder. By centering whiteness in these conversations, our health systems leave out minoritized individuals from these conversations around treatment. And it's interesting that in some ways over the last decade, centering whiteness has had some positive effects. That is that there's renewed advocacy that helps shift public opinion and policies around substance use, leading to destigmatization, remedicalization, and decriminalization of addiction, at least for many white folks. But partly because of the centering of whiteness in our treatment approaches, there's even wider mistrust of healthcare and social services and justice systems by communities of color. And health institutions, until I would argue up until now have made few amends to really address historic harm and trauma. And by centering whiteness in treatment, by not inviting culturally relevant treatment, we haven't been designing our health systems to really center those who have been historically marginalized. And this leads to lower rates of folks seeking treatment due to lack of trust, fear of punishment for substance use, fear of legal repercussions for the family, or just not feeling included in these definitions of substance use disorder or opioid use disorder, right? So we see a lot of folks of color rightly feel that most hospitals don't serve them, right? And or the treatment approaches that are brought forward to them or offered to them don't apply for them. They don't see them within the narrative of this. It's interesting. There have been a few recent studies looking at sort of qualitative studies looking at what folks of color identify, how they identify within the opioid epidemic. And one of the things that's come out is that a lot of times people of color do not identify within the opioid epidemic, even if they have an opioid use disorder. So you might ask in the hospital or clinic setting, around opioid use, and patients may say, that is not an issue for them. But one of the places where I think that this is really important and pertinent to our practice, especially with the rise of fentanyl-laced products, any patient who has a history of substance use disorder, whether it's cocaine, marijuana, amphetamines, or opioids, we should be offering naloxone, and we should be teaching everybody how to use it in case of an overdose. whether or not somebody identifies truly as having an opioid use disorder, because again, they may not actually fit within what they see as the dominant narrative there.
Dr.
I know
Patel,
yeah.
I apologize for interrupting you, but we are over time, unfortunately. So if you could just quickly maybe take a minute to just quickly summarize it, and we'll have to move on to the next session. I apologize.
Yeah, great. Yeah, no worries. I was going to go into sort of really focusing on what does an equity focused on addiction treatment look like, and I'll go through some of these, and this is a non-comprehensive list, and I won't go into details, but really bringing in this idea that Bell Hooks put forward 40 years ago around centering the margins, and again, I won't go into this in more detail. I think a key health equity principle is redistribution of resources, putting resources into the spaces of, really bringing them to minoritized individuals and populations. We need to provide structurally competent care. We need to engage in cultural humility in our care. We need to really address unmet social needs in order to bring people into treatment and retain them within treatment. Practicing harm reduction, practicing trauma-informed care. Again, unfortunately, I won't be able to go into these in more detail here. Here's a few thoughts in terms of specifically around hospitalization. So, a couple of key points. Medication-related treatment needs to be readily and widely available everywhere, anytime somebody sets foot within any space, whether it's the ED, coming in for a surgery, in the inpatient side, going to clinic, seeing a provider at a homeless shelter. It needs to be available anytime somebody is willing and interested in getting any kind of treatment. So that's first and foremost. We need to create the space to make it widely and readily available everywhere. We need to really attend to individuals' multiple needs, right? So not just substance use disorder, but whether that's food insecurity or housing security, things like that will enable us to be able to treat substance use disorders. And engaging in culturally informed counseling and behavioral therapy, really bringing in peer recovery support specialists within our work. And I'll pause there. I kind of leave with a few questions of what could an equity-based approach to substance use treatment during hospitalization look like, and what are some of the challenges in implementation? And I wanted to talk a little bit about harm reduction, and maybe we can come back to that in the future. And I think these slides will get posted, but I'm listing several references that I've used along the way here, and would love to touch base with y'all if you have further thoughts and if we could collaborate more. Thanks, everyone.
Thank you so much, Dr. Patel. I apologize, we had to move on to the next session in the interest of time. ECHO IT, if you could please quickly share the announcement slides. I'll just run through them quickly so we can get on with the case. Next slide, please. So Texas Mood has a network of providers for medication treatment, a network of recovery support services. It also provides hospital-based opioid use disorder screening and treatment. It also provides telementoring through various programs like Project ECHO and Get Waiver Texas. You can also look up the several clinical trials going on its website as well. Slide 3, please. Support Hospital Opioid Use Disorder is a program at Dell Medical School. And they have monthly ECHO community of practice series, monthly generally focused virtual house office hours, and a quarterly OB and the postpartum focused virtual office hours as well. Next slide, please. Our next Shout Community of Practice ECHO is on Thursday, December 16th. Please join us. We have some exciting speakers lined up. Next slide, please. The next virtual buprenorphine DEA-X waiver training is on Saturday, December 11th. Please do register on the Texas Mood website. Next slide, please. The Heroes Helpline provides a free, entirely confidential telephone support and referral service that affords first responders and healthcare workers the opportunity to seek treatment without fear of judgment, stigma, or occupational threats. Please call this confidential helpline or visit heroeshelpline.org for more resources. Next slide, please. For more events and resources, please do visit our website, shouttexas.org. Next slide. Thank you so much. We'll now move on to the case presentation. Dr. Mayenberg, once ECHO IT shares the case, you can take it away. Thank you.
Hi, good afternoon. My name is Lindsay Mayenberg, and I am a clinical pharmacist at Ascension, Texas, practicing at Ascension Seton Northwest. I'm very excited to be here today to share the systems case with you all. And, you know, first I thought it'd be good to kind of share our background here at Northwest. About a year ago, we were fortunate enough to have Dr. Rich Botner, as well as Kirsten Mason, one of our previous clinical pharmacists, come and share a presentation with our administration here at the hospital. And they were able to really convince the administration here that this was something that we could start at this site. Seton Northwest is a community-based hospital. It's non-academic, and it is located in Austin. So we have a pretty urban population, and we see quite a bit of substance use disorders in our hospital. So this seemed like a good fit. We do have a pretty small team here. So gaining provider support was actually pretty easy. However, I will say that, you know, confidence with this disease state as well as treatment is kind of limited. And so we are excited to kind of present our experience thus far and gain your feedback as to how we can move on to next steps in expanding this program. So I've listed a few questions here. I had some trouble, I was conflicted in which question to kind of focus on, but I'll address that shortly. So a few questions and obstacles we're kind of working through is incorporating readiness to change assessment into prescriber training, reducing stigma across the disciplines throughout our hospitalization and each department. Another question, and this comes up quite often, is how to best support patients with polysubstance use disorders. And then this is something everyone experiences, is trying to have seamless transitions of care at follow-up, especially for our uninsured patients. So as I mentioned, Northwest is a community hospital. Our hospitalist team is very invested in the success of this team. And we have currently 4 hospitalists that staff each day, and we have 1 overnight NP that admits patients. At this time, we have 2 ex-waivered hospitalists, and a 3rd hospitalist is undergoing actually she's completed training. She's just waiting for her certification. We've also engaged 2 social workers that are dedicated to providing support for especially the transitions piece for this team. And then we have also recruited a nurse educator, nursing leader to help support opioid withdrawal assessment score training and help me with training about the medications. So I think the main question that I wanted to address today is what is really the best next steps for developing an environment for universal identification and treatment for opioid use disorder in our community hospital. So success would really be achieved if every patient that walks through our door with opioid use disorder had a consistent treatment plan, was able to have follow-up at discharge and be successful in a treatment program with peer support. So currently, as I mentioned, we have a pharmacy champion, we have our 2 ex-waiver hospitalists, 2 social workers. We use Suboxone films as our primary formulary agent for induction. And we do have some MAC clinic contacts that we reach out to in order to set up clinic appointments at discharge. So throughout the year, we've had a lot of competing priorities, as many of you are also experiencing. COVID surges have delayed some of our treatment plans, our coordination of our team, and also has unfortunately probably led to some missed opportunities with patients. A couple of other obstacles, we do still have an environment where different people throughout different departments, there's a bit of stigma around treating patients with opioid use disorder, use of terminology and things that may make the patient uncomfortable. And then additionally, prescribers' confidence with treating with buprenorphine is limited. So we have some things in progress. So we are working on continued training for our prescribers and doing kind of quarterly meetings to, we have a small team at this time, so we can all meet and kind of discuss success stories as well as opportunities. We also have our Del Seaton team that has been very helpful with managing some cases and providing input, which has been extremely useful throughout our building of this team here at the community site. So I'd love to hear any feedback from you all on maybe what we could do to optimize our team, recruit more members, and just provide a universal or I guess a more diffuse, disseminated environment for treating opioid use disorder at this site.
Thanks. Thank you so much, Lindsay. It's Blair Walker. So I'm sort of the lead today, and I obviously am very enthusiastic about this and went through this a few years ago and continue to go through this, but I'm curious to hear what other people's thoughts are first. We have, just to keep mind of time, about 13 minutes to kind of chat about this and try to get some of your questions answered. I think the most important thing to focus on, especially because it turns out you have a lot more support than you realize with us, that you're about to kind of fall in your lap. But Dustin, Dr. DeMoss put in the thing to consider applying for the Shout Texas grant, and then potentially meet with the B team here at Del Seaton, which is what JPS Health Systems did, which was wonderful, and very kind of him to say. I think, what do other people think about, especially we started at an academic hospital, which is used to change, versus community hospitals that might not be as used to that, and what do people think about these questions and suggestions for Lindsay?
So Lindsay, JPS is a community-based hospital. We're kind of a mixed breed, if you will, because we have residencies and fellowships, and so we're a training center, but we're community-based, and community ships do not veer quickly nor easily, and it takes a lot of people pushing said ship to get it to move. And I have a lot of stakeholders involved, and so a lot of people pushing this effort. But the one thing that I was lacking was the time and material to roll out to the hospital wide. And that's where, my experience with the team at Dell, Blair and Rich and colleagues, just phenomenal, and a wealth of knowledge, a lot of ideas bouncing around how to incorporate clinical champions. And so that was a very worthwhile effort, and the application is not hard at all. So I would highly recommend it.
The check is in the mail, Dustin. But no, I thank you for saying that. And I'll just add, being sort of a official site, if you will, like Dustin's talking about, there's still an abundance of resources that we can provide but that are also, kind of freely available out there. It's an interesting time to be doing this work because there's lots of people doing this kind of siloed around the country, and they all have sort of a different approach. And what we've always advocated for is, as long as we're increasing access to care, it doesn't matter, it matters how it looks, but only a little bit, right? I mean, as long as we're being sort of standardized about it, and we're taking certain principles into account, for example, health equity, as Dr. Patel mentioned earlier, and many others, as long as we're kind of doing that, it's going to look a little bit different at every institution. And going back to Blair's comment, I think one of those sort of differentiating things when we look at it across institutions is going to be, is it an academic center? Are there sort of a robust number of learners and residents around, or is it more of a community environment where there's not? And I think that has a lot to do with culture shift. And I might even argue that to some extent, just because there's less numbers of people who need their minds and hearts changed, that it might even be a bit easier to do this at a community center. Maybe, I don't know. And this has not been studied. This is a good research question if anybody wants to take that on. But I am curious to hear from others too about how they see the differences between academic centers and community centers with regard to SUD.
I'll just kind of add in. So at our facility, when I came, we didn't have any addiction services here. And so I'm trying to bring all of that here with the support of the Shouts grant, which has been so helpful, with all the resources and tools and helping me to advocate and know what to say to get these stakeholders. I've had people from our community hospitals in Dallas that they don't have any addiction services. They're really interested in doing this type of work. And I wish I could be in both places to kind of bring the program there. So we're just starting here, but I don't know. I think they're really interested because people outside of psychiatry have reached out to me and like, how do we do this? Can you help us change our protocols? And so that's currently in the work here. So that's just my little experience there. At some point, I hope to go over there and meet everybody and see what their thoughts about addiction is. But I met with one of our hospital councils to work on getting some things put out for us in addiction, and everybody was really supportive of it. So I think our ED is probably our toughest audience, but everybody that I've encountered has been open to change and using supportive language and treating addiction. But I think actually our problem right now is actually doing it, getting that comfort level, because they haven't done it in the past. So.
I'll echo that, Veronica, because getting ER champions is huge, because they're the door to the hospital, right? And so, and also since they have a relatively large footprint in terms of budget, they can, I apologize in advance to any ER guys on the call, they can be pretty squeaky wheels, and they get the attention, which can be to your advantage. If you get an ER champion on your team, that really makes things a lot easier.
Yeah, and I would say, so for a community hospital, you have already started to build this. You've got a team including many important realms of champions, and it's going to depend, like Rich said, on what your hospital system looks like, what your hospital culture looks like. But I'll tell you that we didn't ask permission to do this. We didn't get it out to the whole hospital. We had deliberate preparation before we launched, and we did kind of educate and communicate to some extent, but a lot of the work was as we were doing it. So and certainly your question about stigma, that will change as people start using buprenorphine and seeing the 24-hour turnaround, the 3-hour turnaround of somebody who's really struggling and maybe very irritable and being terrible with all the hospital staff in opioid withdrawal, and how much better they feel and they sort of stabilize and are, able to act in a more respectful way, for instance, and are incredibly grateful. And I think that is the change kind of comes as you're doing it. So I think that part I wouldn't pressure yourself too much about. We have to reduce stigma before we start. It's like, no, go for it. You know, and so I think coming up with a plan and building champions together, and then having kind of that roadmap of what it will look like for the patient so that you can figure out any of the holes you need to fill. You know, for us, we have a retail pharmacy in our hospital on the you know, lobby level. So, you know, how are you going to get them their bridge prescriptions? The little nuts and bolts of it, I would have that all planned out. But I think if you've got people, like, get it, you can go soon. The other thing that I was going to say that, you know, so I'm a psychiatrist. I have dabbled in some Suboxone, but I'm mostly a medical hospital-based psychiatrist, and we weren't really doing much of any Suboxone use, right? So I had some experience. I knew theoretically how it worked. I had ordered it in the hospital and in the psychiatric hospital for withdrawal, but I had never prescribed it before I did B team work, not a single time. I got X-waivered to do this. And so we didn't have any experience in perioperative pain and all the things that we sort of developed experience in. We have a way of secure texting at our hospital, which you have too, but other community hospitals might have something similar. We have Tiger Connect. We're going to have something different soon. We had a core group of, and still do, a buprenorphine team group that had all the like core stakeholders from all the areas. And when we were starting this, we would ping each other. And anytime still that any of us have kind of a complicated case or we need a little nudge for comfort level, like we'll say, hey, I got a conundrum. This is the story, and ping the group and get immediate feedback of that sounds like a good plan. Or yeah, you also might think about this. So we've also developed expertise with methadone, and you know, people forget about naltrexone, but you'll come across somebody who really doesn't want to be on an opioid. And then, you know, we've been so focused on opioids, people forget, well, what about naltrexone? Maybe they want to take that instead. So I think figuring out a way that you can communicate real time on cases or have some case review to help the comfort level of those doctors. And like I said, you are a sister hospital, so I'm going to come. I'm volunteering myself to meet with them. But you know, I think that's how we get this going. It's sort of a grassroots effort of spreading the knowledge, and I think that's where Shout Texas comes in, where these echo clinics come in, so we can run cases and learn from each other in these different areas of the nuances of using these medicines to help people. So we're running out of time. Lindsay, I know we didn't answer everything about your question, but I think there was at least some good discussion. Does anyone have any other thoughts that they wanted to add in? And then I might run through just sort of what we did go over.
I just saw a comment from Dr. Patel. Dr. Patel, would you like to just elaborate about that?
Yeah, I'll just say briefly, you know, thinking of it sounds like there's a handful of providers that are X-waiver, which is fantastic, and seconding all of the things that Dr. Walker just mentioned. But also, you know, anybody can prescribe naloxone, and so it is a way to potentially bring other providers across the board, right? You know, providers with medical degrees, nurses, pharmacists into the conversation and really engage folks into the conversation, and also remembering that not all folks will say that they will identify as having an opioid use disorder, but even somebody who smokes marijuana, who has a concern about marijuana being laced by something, whatever that might be a candidate to get Narcan, right? So it starts opening up these conversations that might not otherwise be able to be opened up. I think that has a ripple effect in terms of stigma reduction within the culture of the hospital space. And so, you know, using Narcan in that way, I mean, one, it saves lives. But two, like, how can we use that to like help you know, from a culture change standpoint within the hospital?
The other thing I would remind everyone is that the X-waiver is not required to use Suboxone or buprenorphine in a medical hospital, and it's not required to prescribe a one-time prescription. Now people can just get registered, so they don't even have to do the training to write a prescription for a one-time Suboxone prescription for somebody. So so there's even less barrier to building more and more champions in your hospital. And I think as a few there build their knowledge and comfort level, they'll disseminate it to all the other doctors too, because that's what's happened here naturally. The other thing that we built in, the last thing I'll say, is that we built in naturally from the beginning, and we're vocal about it, that we were building in what did we call it, Rich and Snehal? You know, like basically we weren't going to be needed anymore. Planned obsolescence, that's what we called it. We built in planned obsolescence. We sort of said, we're here, but we want to teach you how to do this so you don't need us anymore. And that's obviously been different with the different cultures. The surgeons still totally call us and don't want to do it. They want us to prescribe Suboxone for everyone, and so they don't have to write any opioid prescriptions. But the hospital side, the hospitalist side, the medicine side, they're taking it and running with it. If they consult, it's for something really complicated, and often they're just like, I just need a curbside. And that took a few years, but now it's spreading. So I think you'll find it will spread like wildfire because it's such a useful tool. And it's so easy to do. Does anyone have any other thoughts? So just to run through very briefly, and then we'll be done. But it sounds like you have lots of different questions about how to start a B team, so to speak, or how to start kind of taking care of your patients and actually attending to their addiction concerns. You're kind of the things that we sort of talked about were that community hospitals are hard to move. They're sort of set in their ways, so to speak. Definitely having champions, having a deliberate plan that's sort of standardized, and hopefully having some philosophy associated with that, especially, you know, driven by health equity if possible. But also to just kind of go for it, develop your plan, go for it, kind of make it a QI project, so to speak. It's okay to tweak things over time. I think, what's the other good saying? The enemy, what is it? Somebody help me. The enemy of
good is perfect.
Good is perfect. That's right. I wanted to say the enemy of perfect, but it's the opposite. The enemy of good is perfect. Just go for it. It's not going to be perfect. And it's going to be a different recipe for you than in a different hospital. Our B team doesn't need to look the same as your B team. There just needs to be something like that so you can help people get on the medicines they need. And I think the stigma will come off as you do it, as people see that it's not scary and they see that it can be very rewarding work to help people with this medical problem, which is a use disorder. And then also remembering about Shout Texas and the Shout Texas grant, which Dr. Perez talked about too, that has lots of resources. It sounds like even scripts for how to talk to people and try to gain champions and help kind of talk about doing this work. So people can look into that. And that's sort of most of what I wrote down about what we talked about. Thank you so much for coming. Does anybody have any questions or last thoughts?
Just wanted to thank everyone for your feedback, and thank you for inviting me to come today.
Thank you so much. This was an amazing session. Thank you everybody for joining us. As a reminder, to earn the CME and CNE credits, please complete the post-session survey using the link in the chat. We do look forward to seeing you at our next session, which is on December 16th. Have a great rest of your day. Thank you.